ওয়েলকাম ডক্টর দেবাশিস ভট্টাচার্য। নমস্কার,
Hi.
আমার নাম অন্তরা আছে। আমি আজকে মডারেট করব এই প্যানেলটা।
You don't have to speak in Bengali. You can
I
speak
know,
in
but
English.
I'm just trying to. I
That's
was born
nice.
and raised
Very
in
nice.
Calcutta.
Actually, where?
In Calcutta.
Oh,
So
you did your schooling also in Calcutta.
I did my schooling in Calcutta, and then I did my law school from Trinity College in Dublin, and
All
my
right.
CA from Ireland as well. I lived there for about 15 years before I moved back to India. I now live in Bangalore, and I was just sharing with Dr. Kuldeep Singh, our esteemed co-panelist here, who's also joined, who's the dean of academic dean at AIMS Jodhpur, that Bangalore is pretty much now a scene of great chaos in terms of the
Well,
numbers of COVID.
well, the whole world is in chaos, isn't it? Hello, Dr. Kuldeep. I've been
Hello,
hearing a lot of good things about you. A lot of my friends and colleagues seem to know you.
Okay,
And
sir. Yeah, welcome, Dr.
how
Devashish. I've also heard a lot about you.
you've
So
heard?
you
Oh my goodness, everything
have,
derogatory. What?
yeah,
It's
you have,
impossible with a career spanning Oxford and Harvard and pharma and
Thank
biotech
you so
and
much.
consulting
Pleasure.
from what I know, from regulatory all the way to innovation.
Yes.
What I've been reading up about you, Dr. Debashish, you've quite an esteemed career. And I wasn't
Thank
even
you so
aware
much.
that Dr. Kuldeep Singh has a lot of synergies with your own work, because he's actually done some work innovating web-based telemedicine in Nepal,
Excellent.
I think over, if I'm not mistaken, over 8 years ago,
no,
sir?
2001,
2000.
2001,
2000,
Excellent.
2012, right? So
one,
8 years.
one,
2000,
one.
okay,
Yeah,
20
it
years
is
ago
20.
nearly. Wow. Nearly 20
Fantastic.
years ago. That's amazing. So both innovators in their respective fields. Quick introduction. I head Suvitas, which is India's first transition care hospital chain. We have 250-bed hospitals in Hyderabad and Bangalore. We are a pioneer of the transition care space in India, where we
So,
provide a comprehensive solution to the quality of life post-hospitalization. Our specializations are neuro rehab, cardiac rehab, ortho rehab, and geriatric care. We've done over 2,000 such cases. We are award winning in our field. We have pioneered several thought leadership papers across the world. We are a 5-year-old startup, and we're doing very well. We're entering growth phase now. We have also been one of the first to pioneer virtual rehab in the world. And we've done some very successful work in that space since the lockdown started, when we accelerated our work from California to Dubai to rural India. We've been doing some really exciting work in virtual rehab. So we've stuck to what we do. We're not entering the larger telemedicine space, but through online phone and video consultations, we've been doing some great work with post-stroke patients, speech swallow requirements, counseling, of course, and diet, but a comprehensive approach to each patient, where each patient is handled by a team, not just one professional. And that's our specialization. So that's just myself, and just I'm sort of like a bridge between the two, I think, where I'm the person on the ground doing some of this work, and you guys are the thought leaders and the academic leaders in the space. And obviously, Dr. Kuldeep is one of the first thinkers in this space. So it's a very interesting panel, and I hope I'm glad it's getting recorded, because I'd love to share this in the future with my own network. I'll stop
I
now
think
and
you're
I
one of
hand it
the
over
most,
to you, Dr. Devashish, to say a few words.
yeah,
I just want
I
to,
think you're
I'll
one of,
just control the flow, if that's okay, because
no
there's a
problem.
lag in the bandwidth from both of you.
I mean, it's a real pleasure being speaking to you and listening to you, Antara. I think you're one of the most valuable people, especially at this time, because rehabilitation is something which has thrown up so many challenges, and I'm sure you're facing this post-COVID. Nobody really knows exactly which system to go after, and rehabilitation is spanning right not just medically, but also I would imagine the social, economic, even I dare say spiritual uh, aspects of people. And I have some friends in Delhi, I'm sure they'll talk with you, who are trying to actually set up this space, because for the people to come back to normal, you have basically an injured workforce, medical workforce. You have uh, the population which is probably at their lowest levels of self-confidence. and it is so insecure for some. Everybody hasn't had it very good in Corona, and that is probably the understatement of the century. So we'll come to you later. But I think very interestingly, I think this Corona is a very unwelcome reminder that how much health really matters to individuals, society, and the globally in terms of economy, if you have to talk business now. And the future is a very health-driven economy. And I mean, there have been more health improvements from vaccines, antibiotics, sanitation, and nutrition. I mean, today we're not talking about a very reactive, treatment-oriented health system. And I think our basic health infrastructure lies exposed. We have built huge hospitals, and very understandably so, huge hospitals and specialized healthcare, but we've been beaten by a curved ball called coronavirus. We're talking about big vaccines, but I think the biggest vaccine today are simple things like hand washing, wearing masks appropriately, and physical distancing. So there is a need to rethink healthcare, not just rethink healthcare from a healthcare perspective, but from a global economy perspective. And I think finally healthcare has actually got the place it deserves. We are on the high priest table, and we've got center stage. I think people like us, Kuldeep, yourself, myself, we are now occupying very unknowingly and inadvertently very responsible positions. And we need to come together and think very responsibly as to how to transform healthcare from a reactive treatment-oriented to health and wellness. How can we integrate the preventive aspects of healthcare and the rehabilitative aspects of healthcare? I mean, this is from, I'll read this out, that existing treatments, this is from McKinsey, existing treatments and preventive health interventions, the global disease burden could be reduced by about 40% in the next 20 years, a path that we refer to as the healthy growth scenario. I don't know whether it's 40%, this is a hypothesis, but definitely, good healthcare, well-targeted healthcare is very important. And one of the cornerstones, what we have seen, is going to be, digitalization of health. But having said that, using digitalization is not the solution. It is a means to an end. And even digitalization, even like Dr. saying, even my journey was also in the very pre-digital days. So there was so much of resistance to digitalization and telemedicine, and people never understood. But with Corona, it has just opened up. I'm sitting from 6 o'clock till 9 o'clock. People from all walks of life, can we have a digital solution? Fantastic, it's great. But there are certain things that we haven't addressed. We haven't integrated digital etiquette as a part of the training of doctors and healthcare professionals, which Kuldeep will be very keen to get into. We talk about digital health, but we need to know the limitations of digital health. A doctor who is not comfortable in
Absolutely.
seeing the patient, or the patient is not comfortable, we have to actually, give them the support. So I think I'm going to shut up now and let Kuldeep come in. Otherwise, this is going to go all day. There's so much to talk about.
No. I think fascinating. You raised some very exciting thoughts for us to consider. But the baseline that you set was very valid, and I think the topic today that we have on the table is telemedicine, virtual medicine, e-consultations, all the wordings that are going around, and. Before I hand over to Dr. Kuldeep, who's obviously, he's been a thinker in this space well before, I think most people even knew that it was an issue. But the 3 points I think that we will come back to and we should discuss that you raised is, one is the ethics of telemedicine and setting the boundaries and treating it as a responsible solution. The second aspect that you touched upon is moving from reactive to proactive to owning the healthcare infrastructure, not
Absolutely.
just the facilities and the resources, but also the healthcare infrastructure within each human being, each citizen, to ensure that that is robust, from their mental health to their spiritual health to their physical health, etc. So, moving from a ownership of the healthcare infrastructure within the state and what we can do in that context. And then the third aspect that I think you touched upon was the economics of it all, right? And seeing, and there is very valid and well established data as to the impact on the economy of, X number of road traffic accidents go up, how the economy is affected. 74 million diabetics in this country, growing at a rate of 30% year on year, effect on the economy. 1.8 million strokes a year, effect on the economy. So we know that these numbers are there, but we've never really thought it through and arrived at comprehensive decisions taken with all the stakeholders in mind, and getting the governance structure to adopt and therefore build policy around it. So we'll come back to that if you don't mind last. But
Absolutely.
Dr. Kuldeep, I'd like you to please now speak to us, set the context, your thoughts, your inputs on the whole world of telemedicine, pre-COVID, obviously, post-COVID, during COVID, all of that. So seeing you as the expert on this, so please take over, and you need to unmute yourself, please, sir. And Dr. Debashish, if you don't mind, please muting yourself for the moment,
Yeah.
just so we don't have any disturbance. I'll also go on mute. Thank you.
Thank you, Antra. And also, I agree with Dr. Devashish, what he has said about the digitalization of the technology, and it's going to be a very huge impact on the healthcare. COVID has led us to understand that, okay, health is not for free, and also we should be prepared to take our own health. That is very important. And there are many things which are related to health, but most important is that in healthcare also, as in any field, if we say about the like quality improvement, that is a Pareto's law applies. Pareto's law says that 80% of the problems can have just 20% of the solution. They can be solved with just 20% of the solution. So when we say about the infectious disease, nutritional problems, and other healthcare related issues which the common public faces, these 80% can be tackled by 20% of solution. And as Dr. Devashish also stress on the like vaccination, prevention, promotive health, health and wellness centers, and also taking care of the early in the disease course with these simple measures can reduce your like coming to the healthcare tertiary healthcare centers. Now, when we talk about the tertiary healthcare centers, the tertiary healthcare center for 80% of for the 20% of the problem which they come to the hospital has to invest 80% of the solutions. So that means the tertiary care hospital are the biggest. They invest more in the like healthcare resources for only 20% of the problem which come to the hospital. So if we target the 80% outside the hospital and we tackle those and we can reduce it with the 20% of the solution, the hospital inflow of the patient can be reduced. And that's why there are simple solutions are, and the most important solution for the healthcare is communication process. As Dr. Devashish also stressed about that, there is a need for training of the healthcare workers also, developing the etiquettes, digital etiquettes also, which we never taught in our medical schools. So medical schools lack those things which is going to become in the next future. So now the challenge for the medical faculty is to prepare for the future doctors. And for that, we have to take and we have to reduce similarly to the Central Board of Secondary Education, they have reduced the curriculum by 30%. We also need to reduce the curriculum by 50%. And we should only talk about those which are like evergreen things, evergreen science or evergreen medicine to the undergraduates. And for the postgraduate, we go for a little higher level thinking and diagnosing these conditions. But the rest of the 50% should be devoted to the future. That is what the future holds for us. What are the problems which we can anticipate in the future, and how we can tackle those problems with the current knowledge, and how to build on the existing knowledge with the help of evidence-based medicine, by practice-based medicine, by empowering everybody with the communication and professional skills. I think, and the system-based practice is another area which we never taught to our medical students. System-based practices, the same doctor can work not only at the tertiary care center, but should be enabled and empowered to work even in the village level, even in a remotest area where the facilities are not available. So the doctor should not cry that the facilities are not available. They should be able to provide whatever service at their means and skills to the remotest of the people. And Government of India has launched a very ambitious program in 2018 that was known as Ayushman Bharat. But nowadays, the people does only know about the insurance component of that scheme. We are not aware that another component of that scheme is the enabling and empowering the general public. That is the public who are living in the remote area, those who are unorganized, working in the unorganized sector. And that's why they are creating a 150,000 health and wellness centers. Now, this is a huge opportunity for us now for creating the healthcare infrastructure with a low cost facilities in these healthcare wellness centers and empowering our healthcare workers to work in this situation, linking with the school health program, we can markedly reduce the burden to the tertiary care hospital. So the tertiary care hospital can devote more time to the condition for which they are destined to, like doing the very high level of robotic surgeries, high level of care to the patient, intensive care, intensive management, and the very difficult diagnosis and operations. So I think here, what is the role of this technology is one of the component of this technology is communication, and the communication centered around the telemedicine. So when we talk about the telemedicine, I used to discuss with my seniors at that time also in 2001. I presented a paper in US Medicine Meet Virtual Reality, and then they also said that okay, what we are at that time also the US was also not well developed for the real time telemedicine. So it was a more of the like asynchronous telemedicine. So they also agree and they were developing the system to provide the real time telemedicine. So what they had said that we dissociate the tele with the medicine. We just consider the tele. That is a tele part. That is the technology part. So we are developing the robust systems. We are developing the robust system of providing the services, cameras, video, audio. But they never thought about the medical part, medicine part. So that's why there is a need for healthcare workers and the people also to understand that the medicine is also an important component of the telemedicine, and the medicine centered around communication process. When we talk about the communication, I have seen with our experience at AIIMS Jodhpur that simple communication with a feature phone can provide as much content to the general public as possible with the audio video also. So based on the like extent to they have the facility in the periphery, so they can upscale the facility. So if they have just a feature phone, we can provide communication. If they have a WhatsApp, they can do a WhatsApp calling. If they have a like a laptop or a WhatsApp with a Meet, Google Meet, we can go to Google Meet. If they have a more robust telemedicine system in the district hospital, we can connect with them also. So according to the need of the society, we can develop, we should have the telemedicine process which should be enabling and empowering, and it should be like user friendly. At the user end, it should be facilitating. So from the provider end, it is good that we are developing the technology, but at the user end, I think it is important to understand their need, and we have to query and we have to do a questionnaire and research into what are their needs. So what we did at AIIMS Jodhpur, apart from the medical education online, we started with the online portal on 23rd March. And then we started the telemedicine also from 15th of April. Then it was further integrated with the computerized patient management system from 6th June. In the meantime, we developed a new method that is known as reverse telemedicine. This is a new concept. Reverse telemedicine means that the patient is in the hospital along with the faculty member, and the student is sitting at home. So the student is also safe from the COVID, and the patient is also being provided care according to the need. So both are safe. They are sitting as a safe. And the student take the history. They become proficient in asking the questions which are required in the telemedicine part. Because in the telemedicine, you have a very short time. So in a short time, you have to elicit the history, make a diagnosis, and ask the patient what to do next. So the students are learning in this way. Reverse
That's
telemedicine.
fascinating.
Yeah, and this
Fascinating.
this concept is also uh, it is also a mitigation for the myth that the telemedicine is only technology. We can use the simple methods to provide the care to the patient. And
Absolutely.
also, as per the MCI guideline, in the next 2 years, all the doctors, registered medical practitioner, should be certified to provide telemedicine according to the criteria which is there, which is with the Niti Aayog and MCI. So I think, and when we integrate it with the most important problem of the society is the disability because of many conditions. So we can integrate with the AI to provide the augmented reality and the virtual reality. So the patient can be provided those services also remotely. So
Absolutely.
this is our concept at AIMS Jodhpur, and we are trying to develop it further.
That's fantastic. I mean, uh, the entire solution and the way that you all have approached it in a phased manner is fascinating. And I think the people who will be listening to this need some sort of, I think, statistics and numbers around why we are focusing on these issues as revolutionary in terms of the kind of impact that they can make. So I'll just briefly touch upon a couple of things that I'm aware of, and I will request you both, to step in as experts in the field. Number one, let's look at the history, right? India, 70 years approximately old nation, started off 80, 90% being public health infrastructure. Over the last 70, 80 years, we are now 80% private infrastructure. We, as per the WHO, have one of the lowest standards of hospital bed to patient ratio. Even lower is our critical bed ratio to our citizenship ratio, to our population. And given that is the case, a situation like COVID is extremely concerning because you may end up in a situation, and that's the big worry, like Italy did, where you could have saved a lot of people, but you simply don't have enough critical care infrastructure to support it. So the idea is to take some of the existing infrastructure, because it takes time to build these large tertiary quaternary care centers, and reduce the impact of them on the kind of cases that they see, which are not necessary for them to see, which can be managed by primary or secondary care centers, or in this case, telemedicine. I mean, one of the state governments like Delhi has done an incredible job of setting up mohalla clinics, but we need such primary care to come back into to support the infrastructure of the country very, very quickly, number one. Number two, we also have statistics around how far the average patient travels for tertiary care in this country, and I believe the number is around 400 kilometers. So you're talking about huge distances, costs saved for what may not be a necessary ailment that requires that level of care. While of course we all, I think, would agree that the healthcare infrastructure does need to scale up. We need more feet on the street, beds in the buildings, ventilators, technology, etc. So that's in terms of context and the sort of the dire situation we are in the country, in which we need to really ramp up. The secondary aspect of what you said, and I thought that was fabulous, is you cannot look at the technology and the medicine in isolation. They must integrate seamlessly into a system that provides the right solution. And sometimes, for example, what we discovered, the kind of the kind of tech infra you need for a consultation depends on the kind of consultation. So for physiotherapy, for example, you need to have a video consultation, but for diet, you may not. For emotional psychology, you may not. For clinical psychology, you may not. Similarly, for occupational therapy, you need very high quality video. For respiratory therapy, you need extremely, and speech swallow therapy, you need extremely good audio, right? So the kind of tech and infra you need, we are discovering as we practice this, needs to be, and you already identified this years ago, it needs to be agile enough to be able to fit the right solution to provide the right level of care.